We are live now, doctor.
Okay, thank you. So, good evening, respected teachers, seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. It gives me immense pleasure to welcome you all in the 9th masterclass of the online postgraduate teaching program named Kaksha. Kaksha is a PG teaching program by ROS, which will cover all the major topics over a period of next 2 to 3 years, including all the current curriculum of postgraduate teaching in ophthalmology in India. We'll be bringing you the best of national and state faculty experts to share the knowledge and interact with you freely. The residents are also encouraged to put forward their doubts in a fearless manner. Interact, raise your hands, type in your doubts in the chat box. Coming to this class, we have today with us my respected teacher and a very dear friend, Dr. Rashmin Gandhi from Hyderabad, to teach us about the various examination techniques in neuro-ophthalmology cases. About Dr. Rashmin Gandhi, he is the director of Exxon MedTech Private Limited. He's the managing director of Foresight Worldwide. He's a consultant director of Neuro-Ophthalmology in Center for Sight, Hyderabad. He's the editor of Indian Neuro-Ophthalmology Society and adjunct professor in the University of Hyderabad. He has completed his first CS from Edinburgh and Glasgow in 2000, and he's a trainee from Johns Hopkins University, USA. He was a senior ophthalmologist and the director and board member of Shankar Netral Academy from 2000 to 2013, and adjunct professor at IIT Madras from 2009 to 2013. His interests include development of new technologies in ophthalmology, education, and community outreach programs. And he's a research scholar at International Institute of Information Technology, Hyderabad. He was an adjunct faculty, as I told you before, in IIT Madras, and the clinical director of IIT Shankar Netral team, which has developed the mobile eye surgical units. And he leads a team to organize and conduct outreach programs in Zambia, Kenya, Botswana, and is a member of ICO. He has established a teaching institute and hospital and has been leading eye care operations in the Ministry of Health in Iraq, Gabon, Benin, and Togo. He also conducts the vision course for FRCS exams since 2001. He is one of the excellent and the most experienced teachers and authorities in neuro-ophthalmology that you can find. And it's a golden opportunity for all the residents to learn from him. Dr. Rashmin, over to you, sir. You can start sharing your screen.
Thank you, Dr. Vishal. Thank you, entire team at Rajasthan Ophthalmic Society. It's really a pleasure to be part of Kaksha. It has, in a short time, made a great name in the arena of postgraduate teaching, and I'm really honored to be part of it. So as Vishal mentioned, today we are going to talk about examination techniques in neuro-ophthalmology. It's going to be fully interactive two-way class. So even if I'm talking, but if you have a doubt, you can raise your hand, you can stop me, you can unmute yourself and ask your doubts. I'll surely be asking questions. And let's start with this 24-year-old female who's complaining of discomfort around the right eye for the last 3 weeks. She also complains of sudden blurring of vision in the right eye. Vision in the right eye is 6/36. So since this is a class on examination techniques, the first question, of course, is that what would you do next? What clinical examination would you deploy to come to a conclusion here?
And we will check visual acuity, RAPD, color vision.
Yes.
And perimetry.
Lamp examination.
Excellent.
Slit lamp and fundus examination also.
Yes, very good. But please remember...
Contrast sensitivity and...
Yes, absolutely. But please remember, when we approach a case, especially in neuro-ophthalmology, almost all branches in medicine, first and foremost, always don't forget about history. It is part of clinical examination as well, especially in somebody who has acute loss of vision. We need to make sure that we discuss with patient about onset of loss of vision. How did it progress? What happened in the interim 3 weeks? Remember, patient is coming to you after 3 weeks. Whether is there any improvement or is there any deterioration? Is there any progressive loss of vision? So acute loss of vision, these three are very important. After that, whatever you mentioned, Mukesh, you actually came up with almost everything that you need to do to answer this question. Is this a visual pathway lesion and what would have caused it? These are the two questions we have when we have patient with acute loss of vision. And to find out whether this is an acute visual pathway lesion, these are the optic nerve function test that we'll do. As Mukesh very rightly mentioned, visual acuity is one of the important and the first test for the optic nerve function. Pupils swinging flashlight test is the most objective way of assessing optic nerve function. Color vision, visual fields in the clinical setting by 3 ways. By confrontation, we'll discuss about that, Amsler and using a red target, brightness sensitivity, contrast sensitivity, and examination of fundus is not strictly an optic nerve function test, but examination of the optic nerve and the retina will give you a clue as to what's going on. So let's look at all of these one by one. Visual acuity, in what way, Ayushi can probably take this, in what way visual acuity would help you in determining the optic nerve function test or give you a clue that there's something wrong with the visual pathway. Ayushi, would you take this?
So distance vision, near vision, and color vision, visual acuity. In lesions of optic nerve, near vision also gets affected.
Excellent, excellent, very, very good. So that's one pointer you immediately get. A lot of times, patient would notice, especially patients who have anisometropia, they'll notice that one eye is not seeing too well. And we check the visual acuity and you find that the near vision is fine, but sometimes these patients are labeled as having optic nerve problem. So as you very rightly said, optic nerve problem would have reduction of both distance visual acuity and near visual acuity. If it's a refractive error like anisometropia or refractive error in both the eyes, patient would have a reasonably good, especially patients who are myope in this age group, would have reasonably good near vision, and their main problem would be for the distance vision. Very good. Any other clue when we check the visual acuity about the visual pathway lesion? Anything else that will give you a clue that, oh, this is what is going on? All right, so let me talk about this. A lot of times when you ask patient to read the Snellen's vision chart, they might actually miss out letters on one side. So if they are missing out letters on right side consistently, you know that maybe they are having right homonymous hemianopia where they have a field effect, they're missing out on letter on one side. So that's an indirect clue about the visual pathway lesion. So vision check, we talked about it. What about pupils? What test in the pupil that you're going to deploy and how do you do? Yes, Ashika?
Pupillary.
Yes. Let's give you the pupillary.
Pupils will be affected in efferent pathway.
Yes. How would you, what test would you do for?
For REPD particularly.
We will see size of pupil.
Just one minute. Manjula, can you ask the person to mute themselves?
Yes, doctor, will mute, doctor.
Yes, Ayushi.
We will look for anisocoria.
No, we are talking about somebody who is so for this patient, we are looking at swinging flashlight test. Anisocoria is a problem which you will see, and we'll talk about that a little later in the efferent pathway. You're talking about somebody, a patient. So we have to look at the efferent defect. And how do you look for the efferent defect? What test would you do?
Swinging light test.
RAPD.
Yes, you look for RAPD by doing swinging flashlight test. Absolutely right. So Sai Karthik in the chat has written direct and indirect light reflexes, and you're right. Pooja RAPD. Shimran has mentioned swinging flashlight test, and that's the right answer. So we are looking for a swinging flashlight test. Now, how do you perform swinging flashlight test? What are the steps of performing swinging flashlight test? We're talking about only swinging flashlight test. How do you perform? What are the steps? Yes, Ayushi.
It should be in dim room. Patient should be told to focus at distance, and we should put torchlight from temporonasal side of that eye, of one eye, and then swing it to the other eye, and we should look for the pupil reaction.
Very good. So first two steps, you nailed it perfectly right. It should be done. It should be done in dim illumination. Patient should be looking at a distant target, because if he looks at you or if he looks at your torch, you are stimulating accommodation, and patient will have a part of near reflex would have meiosis. So patient should be looking at a far object. It should be in a dim room, a dim light, and it is important because you're looking at relative efferent pupillary defect. You're basically looking at the optic nerve health, one visual tract, anterior visual pathway versus the other. So you perform a swinging flashlight test to make sure that the illumination of the pupil, the angle and the duration is equal for both the eyes. It should not happen that the one eye you are illuminating more, one pupil, than the other, because then you are not getting the right response. So you should make sure that angle and duration of the illumination of each pupil remains the same. Great. So that's swinging flashlight test. Let me show you a video and let me ask you as to what do you see there. So you're performing a swinging flashlight test here. I've purposely slowed down this cartoon for you to see clearly. You don't do it so slowly. Now we're swinging it back to the right eye. And then I'm going to swing it back to the left eye. Wow. What did you see?
Left eye RAPD.
Left eye RAPD.
Absolutely right. Patient in this this demonstration shows that patient has left eye RAPD. Why did you say that? Because when you're going to the left eye was dilating. When you were coming to the right eye, from the left eye, right eye would start constricting, implying that that patient has anterior visual pathway lesion of the left side. Very good. Excellent. So this is just to summarize about the pupillary light reflex and RAPD. Dark room, patient fixates at a distant target. Bright, uniform, focused light source. It should not happen that you have a diffuse light source which has a central scotoma. Then you're not really illuminating pupil properly. Shine light from the side and avoid near reflex, and you should have a better view of the pupil. Very good. So that's about the RAPD. Here is something somebody was mentioning. I think Ayushi was mentioning about anisocoria. So here is an example of anisocoria. Please remember, here you can see patient's pupil size. Right pupil is 4 millimeters, left pupil is 2 millimeters. Can this be optic neuropathy? Can this be right optic neuritis?
The anisocoria denotes the abnormality in efferent pathway.
Exactly, Ayushi. Anisocoria denotes a problem in the efferent pathway. So this is not what you expect in somebody who has an optic nerve disease. Optic nerve disease, efferent pathway is more to do with pupillary light reflex and RAPD. If you find with this kind of vision, if you find anisocoria, you're dealing with efferent pathway problem. All right. Please remember this always. Optic nerve pathology would not cause anisocoria because of the consensual reflex, even if the right eye is blind, but the left visual pathway is fine, because in a normal ambient illumination, the whatever light which is going through the left visual pathway would constrict both left and the right pupil because of the consensual reflex. So it is very unlikely that you'll find anisocoria in a long-standing OPL. Sometimes you may find that that pupil will be a little larger, but traditionally speaking, for your exam, you should always mention that optic nerve pathology would cause RAPD, efferent pathway problem would cause anisocoria, or difference in the size of it. All right. And here is, since we're talking about anisocoria, let's continue our discussion here. What do you see here, Ashika? I put an arrow in front of the left pupil as well. What do you see here? Mukesh, any one of you?
Sir, anisocoria.
Yes, which pupil is smaller, which pupil is larger?
Left smaller, right larger.
Absolutely. Left pupil is smaller than the right pupil. What is the next step? What would you do next? You found this in your exam, or you found this, let's say, in the clinic.
We will look if the
Check
anisocoria
extraocular movement,
Yes.
eyelid position,
Yes.
upper eyelid position.
Okay. Anything that you will do, you come to conclusion
Near reflex.
whether left pupil is at fault or right pupil. What you know right now is only that left pupil is smaller than right pupil. You don't know which one of this is abnormal. You don't know whether left is a normal size and right has become larger, or right is a normal size and left has become smaller. So Shrishti
we will check for different difference in anisocoria in illumination. It increases in dim light or in light.
Absolutely. Srishti, Divyashri, and Shimran has also mentioned it in the chat, and you said it right. You wanted to see now whether this difference in size of the pupil becomes more in a bright environment, in a bright room environment, or it becomes more in a dim light environment. What does it imply? If it becomes more in a dim environment, what does it imply?
In
More dim means a sympathetic loss, sympathetic innervation loss.
Yes, Avishi, that if
in dim light
anisocoria is more in a dim light, you know that you're dealing with a sympathetic problem and the smaller pupil is at fault. Why is that? Because in dim light, normally pupils are supposed to dilate. Now, if there is already a difference in size of pupil, when you switch off the room light, the normal pupil is going to dilate even more, while this pupil is not going to dilate because there is no sympathetic system tone. So anisocoria will become worse in a dim light, implying that the smaller pupil is at fault and you're dealing with sympathetic problems. So in this case, if the anisocoria had become worse in the dim light, you know that you're dealing with left eye sympathetic problem. What is that syndrome called?
Horner syndrome.
Yes, Ayushi. Prachi also mentioned it on the chat. That is, we are talking about, Shimran mentioned it, that we are dealing with Horner syndrome of the left side. Now, quickly tell me what are the other features that you look for in the eye for the Horner syndrome?
Ptosis.
Yes,
meiosis,
Anhidrosis.
Ptosis, mild ptosis, because of involvement of Muller's muscle.
Muller muscle.
More than 2 millimeters, because Muller muscle contributes only 2 millimeters of excursion of the upper eyelid. There is a similar Muller's muscle-like muscle which responds to sympathetic system in the lower eyelid as well. So that's the reason why upper eyelid would droop a little bit by a fraction. So there is a mild ptosis of the upper eyelid. Since there is a similar muscle in the lower eyelid as well, there would be a very marginal lower eyelid ptosis as well. So because now there is a ptosis of the upper and a lower eyelid, you'll have relative enophthalmos because the eye will appear smaller on that side. Obviously, we spoke that the pupil will be smaller on that side. Anything else in the pupil that you look for or you will be able to see?
Heterochromia iridis.
Which patients heterochromia? Which patients?
Long-term Horner syndrome.
Exactly, Mukesh. Very good. Long-term Horners or congenital Horners will also exhibit heterochromia. Very, very good. On the chat as well, Harshit, Manisha, they have mentioned that congenital Horners will exhibit heterochromia. Apart from that, somebody has also, Sai Karthik has mentioned about anhidrosis and ciliospinal reflex. What is also important to note, remember that there is no sympathetic tone on the affected side. So if you look at the pupil carefully, when you throw a light on the pupil, you'll find that the rate of constriction of the pupil to the light will be much faster because parasympathetic system is functioning. Sympathetic system is not functioning. So you'll have a very fast constriction of pupil and then a very slow dilatation to the baseline because of the lack of sympathetic system. So that's another point that you can look at in pupil. So you'll have mild ptosis because of Muller's muscle. You'll have mild lower eyelid ptosis, giving rise to an appearance of inophthalmos. You'll have meiosis, and you'll have a brisk constriction of pupil to the light on the affected side. Apart from that, anhidrosis and loss of spinal reflex always remains as part of the list, especially for theory. All right. So you are now suspecting Horner syndrome in this patient. What would you do next? What is the next step? Let's say patient had and with pain.
Cocaine test, phenylephrine test.
So one way forward is a pharmacological test. Let me tell you that pharmacological tests generally are not really done so frequently, especially the cocaine and hydroxyamphetamine, which are mentioned in textbook, because those substances are not available. They being they are prone to substance abuse, so those chemicals are not readily available. Epinephrine test or phenylephrine test have been described, and that's one way of doing proceeding forwards. But what is more important from the clinical standpoint and also from the knowledge standpoint, that somebody who comes to you with an acute onset Horner syndrome with pain, especially headache or neckache, it becomes a medical emergency.
Carotid dissection?
Yes, these patients can have large vessel dissection. Excellent Aishwarya Kanagaraj also has mentioned it here, and Ayushi mentioned that. Please remember, carotid artery dissection can present to us as painful Horner syndrome, and it is a potentially fatal condition because the vessel wall is opened up. It can throw up an embolus which can lead to MI or stroke. Horner syndrome can be a short note for you as well, so I'll give you some amount of theory here as well. This is another, you can see this picture was given to me by Dr. Devendra Venkatramani from Mumbai. You see there is a mild ptosis of the left side. You can see left pupil is little smaller than the right pupil, and the difference is more in a dim light. In a bright light, this pupil also is constricting, this pupil is constricting. So anisocoria is not so pronounced in a bright room environment, but is pronounced in a dim room environment, signifying that this patient also presented with left Horner syndrome. Now, why it is important, some of these numbers you should remember for your practice and for the exam as well, that painful Horner syndrome can remain isolated in half of the cases. This paper, which came from Atlanta in the US, 1998, they looked at dissecting carotid aneurysm, 146 patients, and they said that 44% of these patients had this, and half of them were isolated. So please remember, Horner syndrome with pain is a medical emergency. You should also look at which area is paining, head and neck. You're probably looking at acute pain in head and acute pain in neck. You're looking at carotid artery dissection. Subacute pain in the chest. You're probably looking at Penco's tumor. Continuous or cyclical pain, cyclical headache. You may be looking at trigeminal neuralgia. So there are three causes of painful Horner syndrome, all systemic, and all these patients can come to us first. This is another number to remember, the 60% of permanent neurological damage. These patients who have carotid artery dissection, 60% of them would have permanent neurological damage, and 5% actually would die. So anisocoria, which was worse in a dim light. Now, these are the causes of some of the causes of anisocoria, which can be worse in a bright light, which implying that there is a problem with the parasympathetic system. And the causes can be third nerve palsy. What would you do if you find a patient with third nerve palsy and anisocoria?
MRI brain, carotid artery aneurysm.
Not carotid artery aneurysm. You are looking at aneurysm. You're right, Ayushi Verma, but you're looking at more. You're more interested in posterior circulation, because posterior communicating artery aneurysm pressing on the third nerve is much more common. You can have internal carotid artery pressing on the third nerve near cavernous sinus, but that's not that common. So what you're interested in, especially for the exam purpose, is that if you have anisocoria, if you have pupillary involvement in a setting of third nerve palsy, you're looking at compressive lesion of the third nerve, and you're interested to rule out aneurysm of posterior communicating artery. So the appropriate examination would be MRI brain in orbit with MRA. And you want to rule out your main area of interest is posterior communicating artery or other artery compressing on the third nerve. So third nerve palsy with anisocoria also is an emergency. Trauma can give rise to anisocoria and can be either pharmacological, can be either if patient has applied atropine in the eye, then you'll have anisocoria, which is worse in bright light. If patient has applied pilocarpine in the eye, then there will be anisocoria, which is worse in a dim light. We spoke about Horner syndrome. Let's look at this patient now. Have a look at it and tell me what do you see here. Patient looking straight. Obviously, this is an anisocoria. Look at it carefully. Tell me what happens to anisocoria. This is a dim light. And before that, there was a bright light. Look at it again. Which eye has a larger pupil?
Left eye.
Left eye. And see here, right pupil is dilating a little bit. So anisocoria became a little less when you dim the light. So this is anisocoria, which was worse in a bright light. What would you do next? Ocular motility, Mukesh had mentioned before, and ocular motility was normal in this patient. There was no ptosis. So there is no feature of third nerve palsy of the left side. What else would you like to know and how would you proceed?
Pilocarpine.
Right, very good. Meanwhile, let me just also tell
Light
you.
mirror dissociation.
Karthik mentioned Pankos tumor, Aishwarya said CT scan, Mudra Puranik mentioned posterior communicating artery, very good. Divyashi mentioned MR angiography. Pooja Keshwani said that left eye pupil probably is larger, same by Mudra. Shimran and Aishwarya said accommodation. Pooja says history of trauma and drop, very good. Yes, first you need to find out whether the patient had sustained any trauma and whether there is any eye drops which patient has used. Now, as you mentioned, and a lot of people have mentioned on the chat as well, you want to proceed with the pilocarpine test because you're suspecting, since there is no history, we're suspecting AD's tonic pupil, right? But before that, let me tell you, you should do this. So here you saw this video that left pupil is larger. Remember this. This is what you should do. You should ask the patient to read for a longer period of time. And you see the left pupil is constricting. When the patient is reading, it is slowly constricting. If you ask the patient to look straight, you'll find there will be a slow redilatation of pupil. That's the reason why AD's pupil is called AD's tonic pupil. When the patient looks to read, you see it will slowly constrict, and then patient looks straight, there'll be a slow redilatation. Versus a normal pupil, you can see there is slow redilatation. Versus a normal pupil will immediately dilate. So this is something which you should do before you jump to pilocarpine test. So you ask the patient to read for around 25 to 30 seconds. If it's an AD's pupil, in most patients, not every AD's pupil will behave that way, but most patients with AD's pupil will find that the pupil is, that affected pupil is slowly constricting. And when you ask the patient then to look straight, it'll slowly redilate. So that's the reason why it's called AD's tonic pupil. And as all of you said, you would like to apply the pilocarpine and see what happens when the pilocarpine is applied. You see the left pupil has become smaller. So which eye would have applied the pilocarpine in this patient?
Left eye.
Left eye, all right. Anybody else have any difference of opinion?
Both eyes.
Both eyes is the right
Both
answer. She also mentioned, Pooja mentioned on the chat that you would apply it in both the eyes because as you have mentioned during our discussion and on the chat that you're looking at the denervation supersensitivity of the affected eye. Now, when you apply diluted pilocarpine in both the eyes, the other eye acts as a control. The right pupil, in this patient, right pupil should not constrict, which it did not, to a diluted pilocarpine, but the left pupil did constrict, confirming your diagnosis of left AD's pupil. So in this segment, we spoke about examination of the patient with anisocoria. First step, always mention what happens to anisocoria when the room lights are off and room lights are on. if it's worse in dark or worse in light. Then we spoke about if you're suspecting AD's pupil, you ask the patient look at the near object for a longer period of time. You'll have a slow constriction and a slow redilatation. You also confirm it by instilling diluted pilocarpine. How would you dilute it? How would you dilute the pilocarpine and how many times? The strength which is required to
0.125%.
0.125.
Yes, Mudra also mentioned, she said that both eyes and 0.125%. So generally, you have a 2% pilocarpine which is available. So if you have a 2% pilocarpine, you dilute it around 16 times. You can use a distilled water or you can use artificial tears. Harshit, you said 8 times dilution of 1% also is the right answer. Generally speaking, you'll have a 2% excess to 2%. So if it's 2%, you dilute it 16 times. Absolutely. So that's about AD's pupil. Now, we went here from RAPD because we said that RAPD is pupillary reaction and isochoria is difference in the pupillary size. So we go back to RAPD because that's the examination technique we are discussing for our patient, which initially came in with discomfort and loss of vision. So can you perform a swinging flashlight test in somebody, let's say one pupil is dilated. Let's say patient has right pupil, which is dilated, and you are suspecting that the right pupil also has an optic nerve injury. Can you perform a swinging flashlight test and come to a decent conclusion?
If the consensual, we'll see the consensual in the opposite eye.
No, so what would happen when you perform a swinging flashlight test? Let's say the patient has a right pupil is dilated, and this pupil also has an optic nerve damage. You're shining a light on the right side. What would happen? Nothing, because pupil is dilated because of trauma or whatever it is. Now, right pupil dilated, right pupil optic nerve injured. What would happen, Tamanna, when I go from here to left side?
Left would dilate, would not constrict.
Right optic nerve is damaged. Left optic nerve is fine.
Left will constrict.
Left will start constricting. Absolutely. Go back here.
Left will dilate.
Nothing will happen.
Yeah.
In swinging flashlight test, you only talk about the pupil which is illuminated. Just remember this, okay? So when you go to right side, right pupil is already dilated because of whatever reason, so nothing you will see here. Come back to the left side, left will start constricting because right visual pathway is damaged, left visual pathway is intact. Clear? So in other words, you would be able to perform swinging flashlight test if right optic nerve was damaged and right pupil was dilated. What if there was a reverse? There was an accidental instillation of atropine of the right side, and now you're suspecting an optic nerve damage of the left side, where the pupil is normal, but the optic nerve is damaged. So what would happen now? Remember, right pupil is dilated, but the right optic nerve is fine. Left pupil is normal, but the left optic nerve is damaged. So now let's do the swinging flashlight test and tell me what would you find. We're shining a light in front of the right eye. Come on now.
Nothing will happen.
Nothing will happen, absolutely. But right optic nerve was fine. Now we are swinging a light to the left eye. Optic nerve damaged.
Optic nerve damaged, so no response.
Sorry?
Dilate.
Left eye will start dilating. Please remember, this optic nerve was fine. So when you are shining a light here, this pupil would have constricted. Now, when you go here, because this optic nerve is damaged, this pupil will start dilating. Go here, nothing will happen. Go here, that pupil will start dilating. So the point we made here is that even if one pupil is dilated for whatever reason, you can still perform the swinging flashlight test. What if patient is one-eyed? One eye has been enucleated.
Use 2 light source. Second is dim illuminated source of light.
No, can you comment on RAPD when, let's say, one is an empty socket? Aishwarya says can't perform. Mudra said can't comment. What do you think here? Tamanna, Mukesh, Ayushi, anybody?
Will
Well,
not call it
say it as
RAPD.
APD that it's just a different
it will
pupillary
have to
defect
become
rather than
relative.
RAPD.
Yes, exactly. See, it's relative, right? So technically speaking, you can't really perform a swinging flashlight test. You can't perform, let's say, right eye is fine and left is empty socket. You can't be doing a swinging flashlight test. But this is something which is sometimes asked in the Viva, is that can you look at the pupil in a one-eyed patient and still comment about optic nerve health? The answer is yes. You perform a test called pupillary edge cycle test. The test is called pupillary edge cycle test. It is performed on a slit lamp. So patient sits on a slit lamp. You illuminate the lower half of the pupil using a horizontal beam of a slit light. So you have a horizontal beam of light which goes through lower 1/3 of the pupil. The beam is horizontal and the illumination is the brightest on a slit lamp. So when the light goes through the lower half of the pupil will constrict. Now there is no light falling on the pupil, so pupil will dilate. Again, it goes through a zone where, well, lower 1/3 has a light going in, so it will constrict. Now there is no light going in, it will dilate. Constrict, dilate. Now, if there is an optic nerve disease, so this process will be much faster because there will be a little bit of constriction, dilation. Normal patient, it would constrict, stay there for a while, and then dilate. Versus in an optic nerve damage where this will happen much faster. There is a number which is given. And so if the pupillary edge cycle, we are supposed to count how many times, that's why it's called pupillary edge cycle time. So how many times this cyclical phenomena got repeated, and that might give you a clue that your patient has an optic nerve damage or does not have an optic nerve damage. So this is more for a theory. Sometimes it is asked, if you just say that pupillary edge cycle time, that should be enough. So that's about pupil. We spoke about efferent pupillary defect. We spoke about anisocoria as well, just by the way, and we covered examination of a patient with Adie's pupil. Remember, we started with that acute loss of vision, and we are actually on the optic nerve function test. So first optic nerve function test we said was visual acuity. We said that near vision is important, and we said that if patient is missing out on letters while reading Snell's chart, it will give me a clue that patient has a visual pathway lesion. In pupil, we spoke about RAPD and swinging flashlight test. Now we come to examination color vision. How would you check color vision using Ischia plates? Because that's the commonest which is used. A lot of times it is kept in the exam. So how do you perform the color vision test using Ischia plates? Anything? There are two specific things. Like in pupil, there were two specific things. Yes, Mukesh.
Sir, plate 1 is for demonstration.
We'll come to that. No, we'll come to that. How do you perform the test? What are the two essential prerequisites? So the prerequisites for performing.
Refractive error should be corrected.
Yes, Ayushi?
Refractive error should be corrected first.
Yes, yes. You have to, especially in somebody who is in a presbyopic age group, you need to make sure that he or she is wearing his presbyopic correction. The other important part is the chart should be properly illuminated. Right? So that's if you're testing it on the chair unit, and if you have a lamp above it, you should switch on the lamp. Make sure that the chart is properly illuminated. Make sure that the patient is wearing the refractive error correction, and then you perform the color vision test monocularly. You always cover one eye and ask the patient to look through the Ischia plates. Always perform it monocularly. You look at the accuracy of what patient says and also compare the speed. So if patient has a mild optic nerve problem, he may be able to read properly, but he would be much smaller in identifying the numbers or the pattern. So that's how we perform the Ischia chart test. And as what Mukesh was trying to say, this is something which you might have to just mug up. The plate 1 is everybody, it's called a test plate. And everybody who has a reasonable near vision would be able to see that 12 on the first plate. If patient who has N12 near vision but says he cannot see 12, You should also think of a non-organic vision loss. Somebody who has a functional vision loss would not be able to see the test plate, even with the reasonable near vision. Somebody asked that what's a reasonable vision, which we are not really, there is no cutoff as such, but anybody who is N12 and above should be giving a very reasonable response. Sometimes if there is a field effect, if there are scotomas, sometimes they may not be able to see it, but by and large, N12 would be where I would expect that patient would respond well. Plate number 229 is where patient would read a different number than what is given. 10 to 17, normal person would observe a pattern. 18 to 21, anomalous observer would observe a pattern. And 22 to 26 is generally used for classification. Generally, if you look at first 16 plates, that should be good enough for our purposes. That is Ishara color vision chart. Is there anything else that you may get from checking color vision? In somebody who has an optic nerve disease, is there any other information that you will gather by checking color vision?
That desaturation?
No, we'll come to desaturation a little later, but can you sort of get a very rough idea as to what would have caused optic neuropathy in this patient? Can you get some rough idea? Anybody?
We have mentioned blue color blindness, red, green or blue, red, green optic nerve, blue for glaucoma.
Yeah. So this is by and large, I would agree with that. But more importantly, I mean, more for your exam purpose, please remember that, because remember color vision, Ishihara's color vision is a screening test. So it's difficult to say red, green, blue, yellow, and say glaucoma versus non-glaucoma, retina versus optic nerve. But more importantly, I mean, those are theoretically right concept. More importantly, in the same patient, when you're checking a Ishihara chart, and if you find that patient's visual acuity, Snellen's visual acuity is reasonably all right, but he has a very severe, very significant dyschromatopsia, he's not really able to see many plates on Ishihara, you know that you are probably dealing with inflammation. If patient has a reasonable Snellen's visual acuity and a reasonable preservation of color vision, you know that you're probably dealing with ischemia of the optic nerve. So this is a very rough guideline, not used clinically so much, but you should be knowing about it because in the exam, you may be asked about this. And sometimes you go by this as well, where you know that patient has a 6/9 vision on Snellen's, a good near vision, but is not really able to see many plates on Ishihara, and you know that that means the color vision deficiency is much more than the Snellen's visual acuity loss. And that's one of the feature of inflammation of the optic nerve or a feature of optic neuritis. So that's something which you should be looking at. So color vision deficiency, Rashmi, you wanted me to repeat, is color vision deficiency. There are three things that we mentioned. The first plate, everybody should be able to see. If somebody who has N12 and more vision and is not able to see number 12, you know that you probably are dealing with non-organic vision loss. That's one of the pointer. You don't make a final diagnosis, but that's one of the pointer that there is an element of non-organic or a functional vision loss. The second point we mentioned is that if color vision deficiency is out of proportion to the Snellen's visual acuity, you're probably dealing with inflammation or optic neuritis. Patient has a good Snellen's vision, but he's able to see only first plate. Then you know that the color vision loss is much more pronounced than the Snellen's visual acuity loss. You're dealing with optic neuritis. If there is a moderate visual impairment and there are few plates on Ishihara that patient is able to read, there is no cutoff number, but let's say that out of 16 patient read 8 or 9 plates, you know that patient has a proportionate loss of color vision and the Snellen's vision, you're probably dealing with ischemia. Color vision loss also will be much more pronounced in somebody who has a predominant disease of papillomacular bundle. Can you tell me two conditions which predominantly affect papillomacular bundle? Before that, let me ask you, since we are going to go to visual fields, what kind of visual field defect you will find in somebody who has a disease which predominantly affects papillomacular bundle? What is a visual field defect you will see? Ankita, you got it right. So the visual field defect that you'll find in somebody who has a papillomacular disease would be central or centrocecal scotoma. Patient would have a central scotoma. The disease is much more severe of that nerve fiber tract. Then it will go up to the blind spot, and then it's called centrocecal scotoma. Central scotoma is right at the fixation. If that central scotoma reaches the blind spot, then that scotoma is called centrocecal scotoma. That tells you that patient is likely to have a disease of papillomacular bundle. And as Ankita very rightly mentioned, LHON is one of the diseases which produces a predominant effect on papillomacular bundle. LHON is a mitochondrial disorder. You know, mitochondria is a powerhouse of the cell. Papillomacular bundle is one of the most active tract in the body, which continuously is working. So even if there is a little damage to the mitochondria there, it will become clinically significant. So LHON or nutritional optic neuropathy would present to you with central or centrocecal scotoma in both the eyes. And that's where you can also see a pronounced color vision deficiency. So that's about the second optic nerve function test, which is color vision. Let's talk about visual fields. I said that visual fields in the clinical setting, in the OPD or in the exam, is tested by three methods: confrontation, Emsler charting, and a red target. Let's talk quickly about confrontation. First, before we go to confrontation, let me ask you guys, is there any role of confrontation in today's day and world? I mean, you have an access, almost everybody has an access to automated perimetry. So why don't you just go ahead and do automated perimetry and get the proper computerized printout, which is age matched with a threshold? Why do we even know about confrontation? Very good. Pooja came up with a great answer. Mudra as well. Pushkar Raj, very good. Very, very good. Very good. So patient who is not ambulatory in a ward, patient, especially in a neurology ward where you're called for an opinion and you want to know what the damage is likely to be, you are adding to the already existent clinical knowledge about the patient, is where you perform a confrontation test to find out what's going on with the visual pathway. Uncooperative patient who cannot sit, they are ambulatory but cannot sit because, let's say, maybe a neck reason or whatever, neck reason, you cannot do the automated perimetry because patient is simply not able to perform that test so often or so easily. Patient who has a profound visual impairment, remember, somebody who has less than 6/60 vision, the sensitivity of automated perimetry to pick up defects goes down. You can do it by using a larger target, but the pattern that you want to see will go down, and then it is better than observed by doing confrontation test. So would anybody want to say what are the steps in confrontation? Would anybody know how would you perform a confrontation test? Gross steps. I mean, confrontation itself is a very big topic. How would you start a confrontation test? Very good. I get this very
The patient and examiner should be at the same level.
Very good. A lot of times we used to say, because it was written in the textbook, that yeah, you sit opposite the patient at the same level, make sure that your knees are touching. Well, that's not a prerequisite. That's not where, even if your knees don't touch, you can still do the confrontation test. So arm's length is fine. Yes, same level. Now go ahead. Yes, you said you had
Examiner and the patient, both the same field should be checked, temporal of the examiner and temporal of the patient. So right eye, if we are examining the right eye of the patient, left eye of the examiner should be checked.
All right. Yeah, I know that's what you probably would have read, but the steps of confrontation begin much before that. So initial few steps, the examiner need not close the eye. Initial few steps, you're not comparing patient's visual field with the examiner's visual field. That comes in for the peripheral defect or the depth of the visual field, the whole extent of the visual field. Initially, you just want to find out whether the patient has any visual field defect. So all the central visual field defects, you can actually, you can uncover them without closing your eye as an examiner. So you can ask the patient to close one of the eyes. Now, this is especially true for somebody who may be writing the Royal College exams. There, a lot of times, the exams go on for days together, for weeks together. And on the day of exam, the examiner is sitting from morning 8 o'clock to night 8 o'clock. And a lot of times they do little tricks to make sure that they are amused. So it used to happen that they will give you a patient with a very poor visual acuity. And then they said, please check the visual field. Please do the confrontation of the right eye. Right eye would have no PL or PL plus vision. So, and they would have told the patient, don't tell that my vision in the right eye is poor. So you ask the patient to close the left eye and then you say, can you see my finger? He said, no. Can you see my finger? He said, no. And then you'll be confused. Besides that, just to find out if the patient has a visual field defect in the center of his vision. So you ask the patient first to close one of the eyes. Let's say I'm closing my left eye. Now you'll ask me, can you see my face? And I'll say yes. So grossly, I have a reasonable central vision. Then you say, can you see my nose? And I say, yes, I can see your nose as well. So that means that there is no small central scotoma or my vision is adequately all right for you to perform a confrontation test. Can you see my face? Can you see my nose? When you are looking at my nose, is any part of my face missing? These are the 3 questions that you'll ask the patient. Patient closes one eye. Can you see my face? Can you see my nose? When you're looking at my nose, is any part of my face missing? So if he says, I cannot see your face, you know that patient's vision, central vision is very poor or has a very large scotoma or very poor vision. He says, I can see your face, but cannot see your nose. You directly know that patient probably has a central scotoma because he's focusing on your nose. When you ask the patient, say, look at my nose, and when you're looking at my nose, is any part of my face missing? The patient says that I cannot see your upper part of your face very well. You know that maybe there is a superior altitudinal defect. He says, I cannot see the lower part of the face. You know that patient has an inferior altitudinal defect. He says, oh yeah, when I'm looking at your nose, I cannot see this part of the face. You know that patient has an hemianopic defect. So straight away, dense visual field defects, you'll be able to uncover just by doing this. Close one eye, ask the patient to say, can you see my face? Can you see my nose? When you're looking at my nose, is any part of my face missing? When I was doing this test in Chennai at a very smart patient, so I said, can you see my face? He said, yes, I can see your face. Can you see my nose? Yes, I can see your nose. When you're looking at my nose, is any part of my face missing? Yes. What? Hair. So I said, well, that's not really what we're looking at. You're right technically, but that's not what we're looking at. So these are the 3 questions which will begin your confrontation. Now, patient says, oh, everything okay. Patient still continues to close one eye. You don't need to close your eye even for this second step. Patient closes one eye. You now project 2 fingers on either side. So we say here and here. And say how many fingers? So patient will say 1 here, 2 here, or he'll say 2. That means that he's not able to see here. We'll say 1, you know that he's not able to see here. How many fingers? How many fingers? How many fingers? And you keep doing it 2-3 times to you know that you're getting a correct answer. So here, if he is given wrong answer for both of this, you know again a superior defect. Both wrong answer for this, you know inferior defect. You know that if I'm a patient and you're projecting here and I cannot see here, you know that there is a temporal defect. Cannot see here, you know there is a nasal defect. That's the second step. Again, for this step, you don't have to close your eye. First step for the central defect, second step for gross hemianopic or altitudinal defect. And then if you have to go to the third step, which is quite rare in today's day and world, is where you would close your eye as well. And then you see, if you're able to see finger here, but patient is not able to see, or he has stopped seeing it way before you stop seeing it, you know that patient may be having a peripheral visual field defect or a constriction of the visual field. So 3 steps, 2 steps, you don't need to close your eye. 3rd step is where you close your eye. If you want to be technically absolutely accurate, or if you're writing one of those Royal College exams, then you have to remember that for the peripheral visual field defect, finger is acceptable, but more than finger, if you can use a small white target of almost half of your pulp, this much white target, and you bring it to the center, that's great. And for the central defect, you use a red target. Whenever you want to chart a central scotoma, use a red color target of this size. So that's about confrontation. 3 basic steps. Nowadays, as I said, it is more useful for your wards and for the day-to-day activity. I have not seen it being asked too often in our Indian exams, though Royal College exams, now still they ask you to perform confrontation tests. There are different other methods of confrontation which used to be asked quite often in 90s, where they'll ask you to chart a blind spot, they'll ask you to chart a macular sparing or macular splitting in hemianopic defect, but all that is not being asked now. So that's about confrontation. Another important, and this is a real patient that we saw in Chennai. This is a 48-year-old male. Let me just look at the chat before I go. Look at the eye, the examiner eye, normal, very good. Yes, we discussed about all that. Now this is a patient who had gone to multiple people. 48-year-old male, so in a presbyopic age group. He said that I'm not able to read too well. And then he went to 2 or 3 places, optical shops, opticians, ophthalmologist, and every time he would get a new glass because he will not be happy with the glass that he would be given. He would come back to that place and say, I'm not able to read. And they'll increase the near vision power a little bit to say, can you see it a little better? And you say, yeah, maybe a little better. Again, you come back saying, I can't read at all. So this is where a very smart, very alert optometrist, when I was working in Shankar Netralaya, she figured out that there is something wrong going on here. It's not really presbyopia. Then she discussed it with another neuro-ophthalmologist friend of ours in Shankar Netralaya, and then they just went at it in the EMSLA charting, and patient actually had a very small hemianopic scotomas, hemiscotomas on either side of the midline because of the small infarct that patient had suffered because of his uncontrolled blood pressure and diabetes. So his near vision difficulties was because he was not able to really concentrate on the numbers because one side of, because it was a small scotoma, he was not able to explain that one part of the visual field is missing, but he was not able to really read from left to right very well. And that was his problem. So that gives you an importance of performing EMSLA charting. EMSLA charting is a very good, generally we reserve it for a retinal problem. We want to say whether patient has micropsia, metamorphopsia. Micropsia is what we want to look for in EMSLA charting. But remember, EMSLA charting also gives you a very good information for the central 5 to 10 degrees of the visual field, and it can be done very quickly. So can anybody explain as to how to perform EMSLA charting? Anybody? Tamanna, Mukesh, how do you perform EMSLA charting?
You must have given it to the patients having AMD, no? Just describe that method.
Yeah, any normal, the way you perform EMSLA charting. It's just that you're gaining extra information in neuro-ophthalmology, but the way of performing EMSLA charting remains the same. Yes, Tamanna.
After near correction, the patient is asked to hold the chart at 1/3 of meter, around 1/3 meter, and covers one eye and look at the center of the grid.
Mm-hmm.
And the patient is asked if he could see any distortion or bending.
All right. So first you say, you very right, very, very right. The procedure is right. There are 3 questions that you ask patient, even in for retina. So when you give the patient the EMSLA charting, monocularly, you say, can you see the central dot? He says, yes, I am able to see the central dot. Keep looking at the central dot. When you're looking at the central dot, can you see all 4 corners? Yes, you can see all four corners. Looking at the central dot, can you see all lines in the Amsler charting? And are these lines straight or wavy? So these are three questions you ask. Central dot, looking at the central dot, four corners, looking at the central dot, all lines, whether they are straight or they are missing. So if they are wavy, you note it down there. They're missing, you note it down saying there might be, because it can happen even in a dense macular edema. Patient might tell you that there are some areas which is not able to see. But as I said, you may also uncover a pattern of a visual field defect even on Amsler charting. Great. So that's about this 30 centimeter distance, as you said, 5 millimeter square subtends one visual angle. Now a brightness sensitivity. Now this is something which is not often done, though it is also called subjective RAPD test. It's a fairly simple test, and it can give you a clue about optic nerve damage. A lot of times it is also used to find out whether a patient has an improvement in the optic nerve condition. So how is it performed? It is performed in a dark room. So the room lights are off. You have a torch of light here, and patient actually looks at the torch here. So it's right in the center torch, and patient looks at the torch, and you essentially perform alternate cover test. You cover one eye and then you cover the other eye. And what you're asking patient is there any difference in the brightness between this eye and this eye, this eye and this eye? Patient who is observant and has an optic nerve disease would be able to very clearly say that the torch is brighter in a normal eye versus the affected eye. Sometimes you may also ask, saying that, oh, in the normal eye, if the brightness is 100, how much it is in the affected eye? And this was in the olden days. This question was used for a follow-up of patients. So you say they will note down in the chart. The patient said right eye 100% brightness, left eye 30% brightness. Comes back after 2 weeks, you repeat the test, and patient says now 60% brightness. Though it's a subjective measure, you still know that there is a clear improvement versus the other eye. Other eye acts as a control. So brightness sensitivity test, also called subjective RAPD test, can be performed using the normal torch light. Can you different types of, Anushri wants to know about different type of Amsler chart. See, I use only the Amsler chart with black lines and white background. I have not used the reverse, that is black background and white lines. I have not used even colored Amsler chart, so I don't know much about them. They have been, I don't know whether sometime at the end of the class, if Vishal has used any of these, he can maybe chip in. So that's about the Amsler charting. And that's about the brightness sensitivity. So that's about the afferent pathway. We covered visual acuity, we covered pupil, we covered color vision, we covered visual fields by confrontation, we covered visual fields by Amsler charting. There is also called red desaturation. Somebody mentioned about red desaturation in the past, during the class. So you take a red pencil. How do you check for red desaturation? Red desaturation, there is 2 steps. One, you keep the pencil here and ask the patient to see, is there any difference in the red color between 2 eyes? And patient who has an optic nerve disease would say that red color appears washed out in the eye which has an optic nerve disease. Other important function of the red color is actually you compare the color of the red between nasal and temporal half. So is this red better or is this red better? Red desaturation in the temporal field is one of the earliest features of chiasmal compression. If you have a pituitary adenoma which is compressing of the chiasm, the compression is not really long enough, chronic enough for patient to have effect on the visual fields or visual acuity, but they can still complain, or they can still demonstrate a red desaturation in the temporal half. So red desaturation is another way by testing fields using a red color. Even red pencil of the same size is fine. It can be used between 2 eyes and between nasal and temporal in the same eye. So these are contrast sensitivity tests. Of course, you use those charts and perform the contrast sensitivity test. It is considered as one of the optic nerve function tests, but you have to remember that contrast sensitivity is really affected much more by the refractive status of the patient, presence of IOL, presence of cataract, and whatnot. So that's about the efferent pathway. We spoke about all optic nerve function tests. We'll move a track a little bit here, and let's look at some of the ocular motility problems as well. We are another, Vishal, another 20 minutes. How much time do I have?
Take as much time you like, sir. We have enough time because it's a very interesting lecture. Yeah.
All right. So let's look at now, let's change tracks and let's look at some of the ocular motility problems. And our basic premise here is the examination techniques. All right. Tell me what's going on here. This is a young man, 34-year-old, looking to the left and looking to the right. Looking to the left, looking to the right. Yeah, quite the vertical movements were fine. Quite an obvious problem that you would have spotted. Tell me what it is. Yes, anybody? Tamanna,
Right
yeah.
eye abduction is limited.
Very good, very good. I mean, there are people who are saying it is DRS. I agree that DRS also would have abduction limitation, but the narrowing of the palpebral fissure was not that impressive here. If it showed up in the video, I would say that that's not significant. I'll give you that hint. So yeah, we'll exclude DRS here, and you say that there is an abduction limitation of the right side. What examination techniques now would you deploy, which will help you to further work up this patient? Imagine that this patient is there for your exam, or he's sitting in front of you in OPD. What would you do next in your OPD? And then we'll talk about the further workup.
Diplopia and hair starting.
All right. Okay. Since we're talking about examination, before that, let me first ask you, since you mentioned about diplopia, what are the questions that you ask if somebody complains of diplopia? What's the first question you ask somebody who complains of double vision? What would you ask?
Is it uniocular or monocular?
Excellent. Whether it's monocular or binocular. Why would you ask that? Excellent. Yes, a lot of people have answered here as well. First is which gaze, and then first is monocular versus binocular, and then you go for which gaze. And let me acknowledge Priyanka, Shimran. Shimran has mentioned Mudra, Ashrit, Tasmia. You all have mentioned Sai Karthik, Manisha. Very good. Yes. So, and Bhagyashri has also given the answer that, oh, so Bhagyashri says that binocular diplopia will rule out neurological conditions. Do you agree, people who are on the hot seat? What do you mean by binocular diplopia? Bhagyashri, if you're here, you can maybe unmute yourself and also come on the hot seat. How do you ask for binocular diplopia?
So we will check for individual eye complaining diplopia from both the eyes. The patient might have binocular diplopia.
No, so what would patient say if he has a binocular diplopia? Let's say this patient has a right abduction deficit. Obviously, he would have a diplopia. What would patient say when you cover, let's say, right eye and then you cover the left eye? What would be the patient's response?
He will complain of double vision in both the eyes.
So in other words, Tasmia actually wrote it very beautifully that if diplopia is present, even on closing either eye, opening both eyes. So basically, diplopia will disappear if you close either of the eye. Then that is binocular diplopia. Diplopia which is present when both eyes are open. It would go away if you close either of the eyes. Monocular diplopia is the diplopia which will be present when, even if you close one eye, let's say you close this eye and patient says no diplopia, but if you close this eye and patient says, oh, I still have a double vision. What would you do if you find a patient with monocular diplopia? What is the next step? Monocular diplopia. Where would you have a problem? Likely to have a problem. So monocular diplopia is a sign of ocular problem. The problem is likely to be in the eye. Very good. Dr. Simpi mentioned anterior segment. Aishwarya said dislocated IOL, keratoconus, Anushri, Ankita cataract, anisometropia, localized muscle palsy is very good. Cortical cataract is what Ankita mentioned. Very good. Yes. So you're looking at problem within the eye and all these problems, astigmatism, uncorrected astigmatism, presence of cataract, astigmatism would cover keratoconus as well, presence of dislocated IOL. These are all causes of monocular diplopia, diplopia which will still persist even if you close either of the eye. Rarely, very rarely, monocular diplopia can be a feature of cortical problem, but that's very rare. Would you be able to tell any test which would, in the OPD, which will differentiate monocular diplopia which comes because of the cortex versus monocular diplopia which is coming from the eye? One simple test.
Pinhole.
Very good. Excellent, Tamanna. Excellent. You put a pinhole in front of the eye. What would happen if patient has a cortical diplopia?
Diplopia will persist in
Excellent.
cortical.
So now approach to a patient diplopia can be an essay question or diplopia can be a short note, and that's the reason why we're covering this. So first, most important question, monocular versus binocular. Monocular diplopia would be because of the problems in the eye. Binocular diplopia is generally because of imbalance or lack of coordination between two eyes. That is where you'll have a binocular diplopia. Now, the cortical diplopia, which is monocular, generally would be polyopia. How do you differentiate from the monocular diplopia of central origin versus monocular diplopia of the ocular origin? There are two differentiating points. The cortical double vision is generally polyopia. There will be multiple visions that a patient would see and would persist even if you put pinhole in front of that eye. While monocular diplopia, it can be polyopia as well, and let's say in cataract, but if you put a pinhole, it is likely to disappear. So first question, monocular versus binocular. Second question, where the diplopia is more, as you had mentioned there, whether it's worsening in the right side, left side, up or down. Is there any maneuver which brings about double vision? And is it a maneuver which relieves double vision? So patient, especially with ocular myasthenia, will say that I sleep, I take rest for some time and my double vision goes away and it comes back when I have worked throughout the day, or it's more in the evening. So what makes it better and what makes it worse? So these are the questions that you will ask patients with double vision. Anyhow, we go back to our gentleman here, and this I get almost always when we say that what would you do next? All of you would end up telling me that you do FDT. Now, force reduction test, remember, is an invasive test, and that's not the first step that you will do. But if this patient is sitting in front of you, you'll not immediately take out your forceps and do this. No, because force reduction test is only when you're not very sure what is going on, and is there a restrictive element to the patient's lack of movement in one eye. But your most important aspect here is to tell, well, again, diplopia charting, Hess charting, these are all tests that you'll perform a little later. When the patient is sitting in front of you, you find that the abduction deficit is there. You don't say, okay, now go and do diplopia charting, go and do Hess charting. No, they are nowadays, diplopia and Hess charting has been restricted more for theoretical discussion or more for follow-up, or if you're not very sure what's going on. But important issue here is For first, yes, fundus, Shristi says fundus and eye spec test. Well, eye spec test, you should be doing it in somebody where you are suspecting oculomycina gravis. Eye spec test works very well when oculomycina gravis presents you with ptosis. It does not work so well in somebody who presents with this ocular motility problem. We'll talk about it a little later. But to answer your query, Aishwarya said CT and MRI. Well, ultimately in neuro-ophthalmology, a lot of times you end up doing CT or MRI or both. But right now, for your exam and for your even for clinical work, Shimran says ask for history of infection, pyrexia, trauma, headache. Yes, good. You want to find out why patient has developed this 6-nerve palsy, if that is what it is. The most important part, examination technique, is you look at the other nerves. And what are the nerves, what are the other cranial nerves that you're interested in somebody who has a suspected right 6-nerve palsy. You want to find out what's happening. Of course, to third, fourth, you already looked at when you check the ocular motility. The second nerve, what is the importance of testing optic nerve in somebody who has a 6-nerve palsy? Anybody? Ankita says 3, 4, 2. Deepika Manam says 7th. Excellent, Deepika. Tasmia Samrin also says facial. Ashit says facial. Excellent, excellent. Very good. 7th nerve is very important. But let's go serial wise and say why optic nerve is important. Very good. Aishwarya, you said orbital apex syndrome. Excellent. The reason or conditions where you have simultaneous effect of both pathology affecting both the 6th nerve and the 2nd nerve, pathology is likely to be in the orbit or the orbital apex, where patient would have a 6th nerve and also would have a vision problem. The other simultaneous, and somebody kept mentioning on the chat about fundus examination, again an optic nerve. What is the importance of fundus examination in somebody who has a 6th nerve palsy? Anything that comes to your mind? Very good, Aishwarya. Papilledema, raised ICT, says Anushri, and that's what. So what is the connection between raised ICT and papilledema and the 6th nerve?
Cavernous sinus thrombus.
Okay, before that?
False localizing sign.
Yes, false localizing sign. What do you mean by that?
Increased IVT.
Nerve is pressed at the petrous apex.
Excellent, excellent. I think Gurpreet answered it, right? Very, very good. The nerve, 6th nerve, goes through a very precarious course. And if the pressure within the cranial cavity is higher, at certain locations and angle, it can get compressed. It can get compressed without any tumor there. That's why it's called false localizing sign. It's just getting compressed because of the overall increase in the pressure within the cranial cavity, and patient would have raised ICD, thereby exhibiting papilledema on the fundus, and would have a 6th nerve palsy. Remember, false localizing sign, 6th nerve as a false localizing sign is much more likely to be bilateral. Please remember that, right? So that's about, so Mutra said long course of abducens now predisposes to compression. That's what we used to believe. Tasmia says increased ICD compresses 6th nerve during long course. Well, we used to believe that it is the long course which makes it predisposed to the pressure within the brain. But remember, 4th nerve, trochlear nerve has a longer course than the 6th nerve. Exactly, Aishwarya. 4th nerve has a longer course, yet it is not really affected by raised ICP so much. So now we know that it's more because of the precarious course that the 6th nerve takes. And Zahara Kotawala mentioned that partly, that abducens nerve gets compressed because of its course. Very good. So what you want to do is 2nd nerve. 3rd, 4th, we checked. 5th nerve, what is the importance of, how do you check for 5th nerve? First of all, examination technique.
Corneal reflex.
Yes, exactly. Corneal sensation, Tamanna. Apart from that, anything else? Corneal sensation is right, and a lot of people have given the right answer. Let me acknowledge them. Tasmia, Shimran, Mudra, Manisha, Prachi, Sai Karthik, George, I don't know what is that, Anushri Lingaya, Ashrit, George, go for the fifth now. Fine. Exactly. Yes. V1, V2, V3, Tasmia face sensation. Exactly. You simultaneously ask for a sensation here, here, and here. You're effectively checking all three division of the fifth now, and corneal sensation, which is important for us. And why it is important in a patient with 6-nerve palsy? Where do you have 6th and 5th nerve together?
In cavernous sign.
Exactly. Very good. First answer given by Priyanka, Anushri, Ashrit, Aishwarya, Ashweta, Shimra. They all said that cavernous sinus, apart orbit, cavernous sinus, and CP angle. These are the regions where 6th and 5th nerve are in close or not so close proximity. Orbit and cavernous sinus you can differentiate by checking optic nerve. If optic nerve is affected, you know you're dealing with an orbital lesion. If the optic nerve is spared, but the 6th and 5th nerve or other nerves are affected, you know that you're dealing with cavernous sinus lesion. So that's why importance of 5th nerve. What is the importance of checking 7th nerve? How do you check for 7th?
Lid lag, leg of thermos, closing of the eye.
Yes, yes, Ayushi, absolutely. Lid lag, closure of the eye. You ask the patient to tightly close the eye, and you find that the eyes are not closing. You ask the patient to raise the eyebrow. Do this. Make sure that you have both the cheeks are filled with air. You ask the patient to move the jaw, and you will have a clear idea about the 7th. What is the importance of the 7th nerve? Yes, raised eyebrows, smile. Very good, Anushri. Tasmia, facial asymmetry. Mudra, which point do you want me to repeat about the orbit versus cavernous sinus? Orbit, orbital apex, and the orbit, 6th and 2nd nerve are together. So that's the reason why if you have a 6th nerve and let's say 5th nerve, you have two nerves which are affected, and you want to differentiate between an orbital lesion and a cavernous sinus lesion. If optic nerve is normal, you're looking at a cavernous sinus lesion. If optic nerve is affected, you're looking at an orbital lesion. So that's the difference. 6th nerve and 7th nerve close in the nucleus. Where is the nucleus? Shimran, Harshit. Where is the nucleus?
Sir, pons.
Pons. Very good, Aisha. The nuclei of 6th and 7th nerve are in the pons. It makes that loop around the 6th nerve nucleus called facial colliculus. Exactly, Ankita Sharma. Now, is there something else that you'll see if there is a pontine lesion? 6th and 7th nerve together is what you're saying. So I agree with you that pons is where 6th and 7th nerve are together. But would you see this kind of picture in why pinpoint pupil? Manisha, why meiosis? Shweta, somebody else also said pinpoint pupil. Mudra, why pinpoint pupil? Mobius syndrome is right, but why pinpoint pupil? You're all talking about pontine hemorrhage or, yeah, exactly, Tasmia. Your pontine hemorrhage or poisoning, which affects the pons. Please remember, those patients would not be sitting like this and you will not be able to take the videograph. Those patients would be much more moribund. So, apart from that, anything else would you see? Somebody who has 6th and 7th nerve because of a pontine lesion. No, 3rd nerve, Ankita, where is the 3rd nerve? 3rd nerve is in midbrain. It's not close to 6th and 7th nerve. We're talking about the pontine lesion. 8th nerve, we'll talk about it, Tasmia. No. Something else that you'll see if it's a pontine lesion. Auditory, Deepika, that also we'll see a little later in the next discussion. Associated.
Ophthalmoplegia.
What would you see? What an ophthalmoplegia? CP angle tumor Vandana is a different region. We are talking about the pons itself first. We'll talk about CP angle a little later.
The PPRF.
Yes. Respiratory impairment would be in medulla, Ashrit. INO would be in MLF, Dr. Shalomith. Respiratory rate decrease, that will be in medulla, little down. So PPRF, yes, Ayushi. So what do you mean by PPRF? Not ophthalmology, something else. Very good.
Horizontal gaze pulse.
Yes, Ayushi and Dr. Maukhika, Dr. Kondapalli. Sorry, I'm sorry for that. I couldn't pronounce it well. Horizontal gaze palsy is what you'll find in somebody who has a pontine lesion with effect of PPRF, because PPRF controls the gaze to the same side. So if you have a pontine lesion which affects the 6th and 7th nerve nucleus, what you're likely to see is a gaze palsy to the right side. Right eye would not abduct, left eye would not abduct. When they ask patient to look to the right, and patient would have a facial nerve involvement. In a CP angle, a lot of people talked about CP angle. In CP angle, the other eye would adduct, so there will not be any gaze palsy. Right eye CP angle problem, right eye would not abduct, left eye would continue to adduct. It may show some nystagmus because of cerebellar involvement. Here, CP angle is where you'll find 8th nerve involvement as well. So 6th and 7th nerve, two places where they get involved together. In the pons nucleus, you'll find a gaze palsy and 7th nerve. In a CP angle, you'll find nystagmus in the other eye, but the gaze palsy will not be there. And 6th and 7th together, you can have effect of on the 8th nerve as well. So ultimately, if you see a patient like this, your first job is to check all these nerves to make sure that you can find out where would you localize the lesion. Is it the orbit? Is it the cavernous sinus? Is it through the pathway of the 6th nerve? Is it pons? Is it CP angle? Where is the effect of, or where is the lesion likely to be? Okay, so that's what you'll do first. CP angle tumor, no ptosis. CP angle tumor, you will have leg-ophthalmos because the 7th nerve is gone. Manisha. So that's about the 6th nerve and the workup. You will look at the other nerves. Then, as you all said, we look at the facial asymmetry, look at the hemiplegia, all those syndromes which are theoretically given to you, and that's how you work up our examination technique for a 6th nerve palsy. Now, what do you see here? What did you see here?
So complete of thermoplegia of right eye with 7th nerve palsy.
Why did you say 7th nerve?
Ptosis.
Ptosis would not. It will be opposite. 7th nerve would have leg-ophthalmos. Ptosis would be 3rd nerve. In 7th nerve, you will not be able to close the eye. There will be leg-ophthalmos. So yes, complete ophthalmology, I agree with you. Where would you localize the lesion? For that, as we discussed, you need to know whether optic nerve is functioning or not functioning. If the optic nerve is not functioning, localize it to the orbital process, orbital apex. Very right, Bhageshi. Absolutely. Seema, Dr. Kondapalli. No, CPO would be bilateral, Aishwarya. It'll have similar kind of, and probably I'll show you the video of CPO, where both eyes would not move. This is a unilateral process. The other eye is going all right. Orbital apex, Ashrit, Shimran, I'll agree with you. Provided you know that the optic nerve is not functioning. It can also be cavernous sinus, and you'll have all these nerves are there in the cavernous sinus, and you find that the eyes are not moving cavernous sinus level, but this is much more likely to be orbital process. Posterior communicating artery aneurysm, Manisha, would cause only the 3rd nerve palsy. Here, even the 6th nerve is gone. CCF would have some impact on the other eye as well, Ashrit. It's a good thought. CCF can produce this kind of loss of ocular motility, but you would have some impact of the other eye. Okay, So that's ocular motility. I hope that you got the drift as to what you're likely to do. Now let's look at some more ocular motility. This is a 65-year-old female who was told that he has an age-related ptosis of the right side, and that requires a surgery. Tell me what you find. We're checking ocular motility here. What did you see?
Fatigue.
Shrishti Kular has got it right. Harshit says is myasthenia. No, Harshit, there is a ptosis. If you see, once you keep seeing this patient, you see the ptosis has really increased. Now they say ptosis in both the eyes. It's like right eye is like almost closed and the left eye also is drooped down, signifying that patient has no Tejasvita. This is not INO. This is fatigability, which is telling you that the patient has, and you can see patient is clearly now inconvenienced because the muscles are so fatigued. So this is a fatigability test of ocular myasthenia gravis. So what all would you do examination technique in somebody who has ocular myasthenia gravis? You're right, division ocular myasthenia, Priyanka fatigability, Madhu Sharma, myasthenia, ice pack, Sai Karthik ice pack. Before that, before ice pack. Anybody on the hot seat? Diurnal variation.
Diurnal variation.
Variation of ptosis with
Yes.
binaural.
Yes, that's in the history part. Very, very good. The test that you'll perform in your OPD would be one, you will check for orbicularis oculi tone. You ask the patient to tightly shut the eye and lift up eye. And in the patient who has loss of orbicularis oculi tone, which is one of the early signs of ocular myasthenia, you will easily be able to open the eye. Fatigability was demonstrated. You also look at Cogan's lid twitch. Ask the patient to look down for around 30 seconds, and then ask them to make the upward saccades. Patient who has myasthenia would exhibit a Cogan's lid twitch where the eyelid will go up, will do a little flutter like this. That's called Cogan's lid twitch. So orbicularis oculi tone, fatigability, Cogan's lid twitch will also sometimes can demonstrate seesaw ptosis. So you lift up one eyelid, and because of Herring's law, you find that the other eyelid droops down. That's called seesaw ptosis or enhancement of ptosis. That's also one of the features that can be demonstrated in ocular myasthenia. We'll confirm it in the OPD by using ice pack test, where you can apply peak test is right as well. Good, Radhika and Shimran. And Radhika also mentioned about Cogan's lid. Prachi mentioned about it. Very good. And the ice test, you apply the ice for around 2 minutes. You'll find that dramatic increase in the lid aperture. It doesn't work as well in somebody who has a complete ptosis. It works well. In incomplete ptosis, it does not. Ice test does not work so well in somebody who has a complete ptosis or somebody who has an ocular motility problem. Pharmacologically, it used to be diagnosed by doing tensilon test, but that's not really available so easily now. So neostigmine test is which can be done for the pharmacological testing to confirm, inject neostigmine. You remember neostigmine has to be injected in the ICU setting. I really don't do that too often now. But a pharmacological test for you to know is neostigmine and tensilon test. Both should be done in the ICU setting. Tensilon test, you will find that the effect will be immediate. Neostigmine takes around half an hour for it to have an impact. And neostigmine is much more useful in somebody who has predominant ocular motility problem, while tensilon has a dramatic result in both ocular motility and ptosis. Neostigmine also can improve ptosis, but ocular motility is much more responsive to neostigmine. The confirmation of ocular myasthenia, not directly related to clinical examination technique, would be you can do certain blood tests. You can look at the antibody, though you have to remember that pure ocular form of myasthenia, these antibodies are not really that commonly seen. And you can do electrophysiological tests by repeated nerve fiber stimulation test, where you can see a decremental response. So that's about the Prachi wants to know what is peak test. You ask the patient to close the eye. Now, even the orbicularis would be affected by myasthenia. So patient will not be able to close the eye for a very long time, and it will appear as if he's peaking. It's not because he's peaking, but he's not able to close the eye for a longer period of time. So that's the peak test. All right. So that, I think, brings us to the end of clinical examination techniques. There are a few techniques which you would have to repeat, look at it carefully, and then if you have any doubts, you can always reach out to us later, to Vishal or to me directly. And if there are any further questions, I'll be happy to take it. Otherwise, we'll go to the question to decide the winner of this.
You can post all your pending questions in the WhatsApp group, which is in the link, and you can join that group and we can forward the questions to Dr. Rashmin later on.
Okay.
Sir, how much time do you think we should give the participants for the questions? What is the difficulty level? 10 seconds, 15 seconds?
I think, how are they going to respond? They're going to write.
They'll have to type it, and no verbal answers will be accepted. Whoever types in the first and is the most accurate answer will be given the prize.
Perfect. Perfect. Then we can give around 5 to 7 seconds.
Okay.
And some of the questions are descriptive. So once I have read the question, maybe give around 7 seconds and let them answer, or maybe 10 seconds, and that's fine.
Okay. Okay, sir. Okay.
All right. So can I go to the quiz now?
Yes, sir. Please go ahead.
All right. So there are 3 questions, guys. It's you can work it out. It's not that difficult. It's related to partly or entirely to what we discussed today. So question number 1 is this. This is a long description which somebody gives. It's not sufficient to find that if pupil contracts well or fairly well on exposure, the eye must also be kept under direct stimulation of light and the pupil washed as to whether or not it shows that secondary dilatation under continued exposure that is found associated with the amblyopia of the retroocular neuritis. If the vision of one eye or only eye is affected, it is important to compare the behavior of the 2 pupils when stimulated directly or consensually. Thus, in partial affection of the right optic nerve, the right pupil will show this secondary dilatation exposure to direct stimulation, while the left pupil will show the same behavior on consensual stimulation. A long description of something which we discussed. Who wrote this?
Can you repeat the question, sir?
Who wrote this?
Who wrote this description? Fine.
Yes, a scientist who wrote this. The description is very good. You know that it is a British scientist because the way he has described it. And I think the answers, I'll just look at the answer and I will wait for some time and then I'll tell you.
Yes, sure.
You tell me once the time is done and I'll tell you who.
The time is done, sir. Yeah.
Done. Okay, perfect. So we got the answer from Ayushi, Anushri, Manisha, Pushkar, Vandna, and Tasmiya. Let me tell you, the first to reach the correct answer was Manisha Singh. It was Robert Marcus Gunn. The description of RAPD, he was the first one to describe RAPD, and that's why sometimes it's called a Marcus Gunn pupil. Vandna Sanup was the second one to the right answer, and Tasmiya Submarine was the third one to the right answer.
Manisha, congratulations, you win the grand prize 1. Can you tell me where are you from? Manisha?
Manisha Singh. Maybe camera shy.
Okay, we'll find out. Army Hospital, RNR, Delhi. Good, Manisha.
Perfect. Let's go to the second question.
Okay.
All right. Second question is, we are describing this by the name of Johann Frederick something. It's also called CBH, adding the name of Claude Bernard, who also described this condition. And in France, it's called François Porphyre de Petit. I hope I pronounce it right. Otherwise, pardon my French. So we are talking about a condition. We call it by Johann Frederick H. It's also called CBH. Claude Bernard name was added. And in France, it's also called François Porphyre de Petit syndrome. Just tell me, what are we talking about?
Okay, time's up. Now you can see the answer.
All right, time's up. And Tasmia, Priyanka, Vandana, Nimisha, Nupur, and okay, Nish is only okay, right. So we would we'll split this between Tasmia and Nimisha, because it is Horner syndrome, not really reverse Horner's, but I would give it to you because you were first off the block.
So Tasmia and Nimisha answered that correctly, and it's Honda syndrome, right, sir?
Yes, that's right. And the third question, this you have to be very quick, guys. It's a very simple question. Here we go. Early diabetic macular edema can present with RAPD, true or false?
You have to, the complete answer should, include an explanation also, I think. The correct answer.
So we will give it to, is the time up?
Yeah, time's up.
Okay, so we'll give it to Anishri. As you said, yeah, I mean, there are very rarely you can have RAPD here, but an early diabetic macular edema, you're not likely to have it. So Anushri Lingaya came to the party first. So we'll give it to her.
Anushri Linga, yeah. Anushri, where are you from? Anushri, I'm from SDM Dharwad. Excellent answer.
Fantastic.
Thank you, sir.
All right. So if we are done, then thank you so much.
You can stop sharing. Yes, sir.
Thank you, Vishal, and thank you, entire team at Rajasthan Ophthalmic Society for giving me this opportunity. I hope you guys enjoyed it.
Thank you, sir. This has been a wonderful Kaksha on neuro-ophthalmological examination techniques. It's a vast topic, I agree, and it's impossible to cover everything. But a very well explained and a very comprehensive presentation, especially for those students who are, preparing for the Royal College examinations. A lot of a big chunk of these questions are from neuro-ophthalmology, and they ask you to perform these tests. Not just theory will suffice your passing this exam. You have to know the practical aspects also. And if you have any doubts, you can forward it to me in the WhatsApp group, and I'll come back with the answers from Dr. Rashmin. And thank you all the residents, ROS executive, teachers, and especially Rashmin sir for the excellent teaching. Never seen a vibrant chat box like this before. We look forward to the next class in the coming weeks with more residents on the hot seat. Thank you, and keep giving your feedback and suggestions for the Kaksha experience to improve. Do subscribe to the ROS online YouTube channel for all the previously uploaded and the current Kaksha which will be uploaded. And thank you again. Good night from Team ROS. Thank you, sir. Thank you so much.
Thank you. Bye-bye.
Bye-bye, sir. Bye-bye.